Surgical treatment for hallux valgus. As we explained previously in video titled, Bunion, hallux valgus, a hallux valgus, also known as a bunion, is a deformity of the first metatarsophalangeal joint, MTP. It is characterized by medial inward deviation of the first metatarsal and outer lateral deviation with or without rotation of the big toe. Hallux valgus deformity is one of the most common forefoot deformities. It causes symptoms on the inner edge of the foot. The non-surgical treatment may relieve symptoms, but it can't correct the deformity. The surgery is indicated if the symptoms are severe or persistent, if you have trouble walking, and the symptoms do not improve with conservative management. Depending on various factors like the age, activity level, and the severity of the deformity, your surgeon will choose proper surgical procedure. Hallux valgus evaluation. The main investigation used to assess the level of hallux valgus is plain radiography. Radiographic measurements should be performed on anteroposterior weight-bearing view. The most common measurements include the hallux valgus angle, HVA, the intermetatarsal angle, IMA, and the distal metatarsal articular angle, DMAA, and hallux valgus interphalangeus, HVI. The hallux valgus angle, HVA. The angle created between the longitudinal axis of the first metatarsal and the longitudinal axis of the hallux. Historically, an angle greater than 15 degrees was considered abnormal. Contemporary research suggests an angle of 20 degrees or greater is abnormal. Intermetatarsal angle, IMA. The angle determined by the bisection of the longitudinal axes of the first and second metatarsals. An angle less than 9 degrees is considered normal. The distal metatarsal articular angle, DMAA, is the angle formed between the line perpendicular to the line drawn at the base of the articular surface of the metatarsal head and the longitudinal axis of the metatarsal. An angle less than 10 degrees is considered normal. Hallux valgus interphalangeus, HVI, between longitudinal axis of proximal phalanx and distal phalanx. An angle less than 10 degrees is considered normal. Surgical procedures. There are different types of surgeries to correct a bunion. The aim of surgery is to realign the foot bones, correct the deformity and relieve pain. We will prescribe the most common procedures are used nowadays. Bunionectomy. In a bunionectomy, a surgeon shaves off the excess bone on the outside of your first metatarsal bone. This procedure is always done in conjunction with all other procedures. Modified McBride includes release of adductor from lateral sesamoid and from the base of proximal phalanx and lateral capsulotomy. Original McBride has been abandoned. It also includes lateral sesamoidectomy. This procedure is usually used in conjunction with the other procedures. Chevron procedure. A V-shaped osteotomy of the distal first metatarsal is created, allowing the first metatarsal to be shifted laterally back into a normal alignment, then fixed by pins and screws. Commonly used for mild to moderate deformities. IMA less than 13. HVA is less than or equal to 40. Osteotomy can be performed in two planes, biplanar distal chevron, to correct increased DMAA. Scarf procedure. A longitudinal osteotomy is made within the shaft of the first metatarsal, for the distal portion to be moved laterally and fixed with screws. It is useful for when the deformity is moderate to severe. Ludloff osteotomy. Oblique osteotomy of the proximal 2/3 of the first metatarsal in a proximal dorsal to distal plantar direction, and lateral rotation of the distal fragment around a proximally placed screw, and fixation with a screw or a plate. It is useful for when the deformity is moderate to severe. Other types of proximal osteotomy. The proximal osteotomy of the first metatarsal is done and the bone is moved to its normal position and fixed with a plate and screws. This procedure is used in severe cases and may be accompanied by a distal osteotomy in very severe cases or if the DMAA articular angle is greater than 15 degrees. The osteotomy can be made in a V shape and is called a proximal chevron osteotomy, or an open osteotomy and fixed with a special plate. A kin osteotomy. In this procedure, your surgeon makes a small cut in the proximal phalanx and removes a wedge of bone to straighten the big toe. The bony fragments are then stabilized. This procedure may be performed as a single procedure if the primary deformity at the level of the interphalangeal joint, as if HVI is greater than 10, are combined with other procedures in moderate to severe cases. Metatarsophalangeal joint arthrodesis. The surgeon fuses the proximal phalanx and the first metatarsal by removing the MTP joint surfaces, then stabilizes the bones with screws and plate. This procedure is used for severe MTP osteoarthritis, rheumatoid arthritis, gout, Down syndrome, cerebral palsy, and Ehlers-Danlos. Lapidus procedure. The surgeon fuses the base of the first metatarsal and medial cuneiform. Often used when the underlying cause is tarsometatarsal joint hypermobility, or in very severe cases when the IMA angle is too large, or in the case of degeneration of the first tarsometatarsal joint. First cuneiform osteotomy. In severe deformity in young patient with open physes, fixation with plate or staplers and bone grafting may be required. Keller procedure. The surgeon resects the base of proximal phalanx of the big toe. Indicated only in older patients with reduced functional demands. Recovery and post-op rehabilitation. Recovery varies with each person. Follow the instructions from the surgeon strictly to prevent the bones from shifting and the bunion correction failing. Elevate the foot to minimize swelling as much as possible for the first 6 weeks. It is common to have some swelling in your foot for 3 months, but sometimes up to 6 months following surgery. Fortunately, however, with modern techniques available, you will not need a plaster cast and you can walk on your foot from day one. Generally, the time taken for the bone to heal is around 6 weeks. In this time, you will use a special forefoot relief shoe, where the weight is taken on the heel rather than the forefoot. At 6 weeks following the surgery, if X-rays are satisfactory, you will be asked to remove the shoe and you can wear a comfortable and wide-fitting shoe. After around 3 to 6 months, the foot can resume a normal function without any limitations and you can return to wearing your favorite shoes and participating in sporting activities. Following surgery, a physical therapist can help you restore the strength and movement of your big toe, reduce pain, and allow you to return to the highest level of function possible. Patients having had only the left foot operated on will be able to drive an automatic car within 2 weeks. Those who have had an operation on the right side will be able to drive after about 6 to 8 weeks. Going back to work will depend on the type of work you do. If you have a desk job, you may be able to return to work after 2 to 4 weeks. If you do manual work where there would be a lot of pressure on the foot, then you may need 8 to 12 weeks off work.